Hello, my name is Esme Duprez, and I'm joined today by Dr. Caroly Bischoff and Dr. Caroly Rennels to discuss their recent article in the Journal of Aid and Dying Medicine that unpacks the fascinating connection between aid and dying and the neurodegenerative disease known as ALS. The title of the article aptly describes what it explores: disproportionate use of aid and dying among people with ALS, why ALS aid and dying requests are common while ALS is rare. Let me first give a bit of background about Caroly and Caroly, who co-wrote this article along with 6 others. Caroly Bischoff currently directs the Outpatient Palliative Care Service at UCSF. Caroly Rennels recently began her career as a palliative care physician, also at UCSF. Caroly and Caroly both work directly with patients there, in addition to conducting and publishing research. As for me, I'm an investigative reporter who has written about aid and dying for Bloomberg News and Bloomberg Businessweek magazine, and I am currently working on a book about the topic for an imprint of Simon & Schuster. I also have a personal connection to the material we'll be talking about today. My father, in 2020, became one of the first people in our home state of Maine to die via aid and dying. He had ALS. It wasn't until much later that I learned that he was very much not alone. And I remember wanting to learn more about why people thought this connection between ALS and aid and dying existed and was so strong. Then came Caroly and Caroly's paper exploring just that, and I'm thrilled to get to talk to them more about it today. Caroly, let's start with a quick definition of ALS. What is it, and what happens to people who have it?
ALS is a progressive neurodegenerative disease that affects motor neurons in the brain and spinal cord, such that people with ALS, or amyotrophic lateral sclerosis, lose their ability to move their muscles. There's different forms of ALS, including a limb onset form where people develop weakness in their legs and arms first. And there's another form, bulbar onset ALS, where people lose their ability to speak and swallow first. But really, regardless of what type of ALS a person has, they can go on to lose strength in all of their major muscle groups and have near total paralysis. Ultimately, people with ALS usually die of respiratory failure when the muscles of their breathing become weak. It's also worth noting that though ALS can be associated with some subtle cognitive changes, and about 15% of people with ALS do develop dementia in a frontotemporal dementia, most people with ALS maintain their cognition throughout the illness and maintain their ability to make choices about their own medical care.
I remember learning many years ago that people with cancer make up the bulk of patients pursuing aid and dying in absolute terms. But that's largely because cancer is so common among the general population, as you discuss in your paper. It wasn't until much later that I learned about the connection between aid and dying and ALS, how, despite being a rare disease among the general population, ALS patients are much more likely than those with cancer on a relative basis to pursue aid and dying. When did you begin to notice this phenomenon, and how does it play out in your own practice?
Both Caroly and I see a lot of people with ALS as part of our palliative care practice. And we certainly had that subjective sense from our clinical practice that this is a patient population where aid and dying is often on their minds. And in fact, it's often on their minds quite early on in the disease course.
And so we set out to explore potential motivations about why that was true.
What did you find? Can you tell us about the article's key findings, and what do clinicians working in aid and dying care need to know?
Our group proposes 4 potential motivations that lead to a higher relative prevalence of aid and dying requests among people living with ALS. The first one is the desire for control over the end of life and the end of life process. We propose that it may be more relevant or more powerful among people living with ALS because of the very nature of the disease, where loss of function, loss of ability to participate in activities that bring joy are progressive, and where so much control over life, physical movements, is lost. And our group wondered whether that ongoing series of losses and loss of control prompted a desire to take kind of more agency and more control over the end of life. A second possible motivation ties with that one and is about the relentlessness of the disease course. So we know ALS to be a progressive neurodegenerative disease, meaning that once a function, a muscle function or a physical function is lost, that function does not come back and decreases over time. And we hypothesize that this sense that there's not a meaningful chance of improvement day to day may lead people to consider aid in dying more frequently.
The third motivation that our group focused on is that people with ALS often die from respiratory failure. Additionally, many people with ALS might lose their ability to swallow and might fear really scary choking episodes. They try to emphasize the ways in which we can manage shortness of breath. We can help people be comfortable even as they die from progressive respiratory failure. But I think still, despite that, the thought of dying from respiratory failure is something that many people would prefer to avoid. ALS is an illness where there's a high level of dependence. People often need a lot of help to care for themselves, and that high level of dependence can go on for many months or even years. I think many people with ALS don't want to burden their loved ones with the need to care for them. Even if their loved ones don't see that care as being a burden, I think many people with ALS fear needing that much help and being in a condition where they're that dependent.
You also address in your piece how the universal requirement among U.S. aid in dying laws that patients self-administer the drugs can impact people with ALS differently than other qualifying patients and even other patients with other neurodegenerative diseases. Can you explain that?
One of the requirements in all of our U.S. aid in dying laws is that patients self-administer the medicines by mouth or into their gut through a feeding tube or a rectal tube, for example. And people with ALS often lose their ability to swallow. They often also lose their ability to use their hands. They may not have enough hand dexterity or strength to depress the plunger and administer a medicine through a feeding tube. People with ALS who feel strongly about having aid in dying as an option often worry about losing those critical abilities. So that puts a little bit of a time pressure on them to make a decision about whether they want to use aid in dying medicines or not.
This can create a situation where people living with ALS who are considering aid in dying feel a sense of anxiety or even time pressure to complete the process for fear that they may lose the ability to self-administer.
We never want anyone with ALS or otherwise to feel any pressure to use aid in dying medicines before they're ready. However, I think many people with ALS do experience that requirement that they self-ingest as a source of pressure that they feel.
We also need to acknowledge that although we did include a person living with ALS and a care partner in our focus group, we don't make any assumption that we've comprehensively captured all of the possible motivations.
I think a really important next step that is already being planned is to gather more data and perspectives from people living with the illness and their care partners.
When it comes to helping ALS patients have more control, where does the role of informed consent and making sure that patients know that aid in dying is an option where it's legal, what is the role that that plays, and how does that play out within the group that you worked with on this article?
Even feeling the flexibility, the freedom, and the non-judgmental space to speak about this option of aid in dying brought patients some comfort and some sense of control immediately without necessarily going through all of the logistics and legal steps of obtaining or ingesting the medication. We know that the vast majority of people living with ALS do not pursue aid in dying, and we know that of the people who initiate a request or an inquiry about aid in dying, only a small percentage will go on to self-administer the medications. We find that really opening that non-judgmental space and discussing the full array of options that are available to patients, from palliative care services to a service like hospice to aid in dying can give people a sense of agency and control that they may not otherwise experience.
I'd like to unpack a bit more one of the four main motivations you talk about in the piece, this worry about ALS patients or anyone with a serious illness feeling like they're a burden on others. As I read your article, I noticed you didn't cast these feelings of being a burden in any particular light. And that stood out to me, because feelings like this often get cast in a negative light, as if to feel like a burden and to want to do something about it is inherently a bad thing. Of course, that can be true. It can be bad. It can also be a loving gesture of altruism, and it feels like that possibility too often gets left out. How do you two think about this?
There's a very strong instinct for those of us when we hear that someone worries they're about being a burden to others. We want to reassure them, you're not a burden. We might want to ask their loved one to speak up. Do you feel like you're being burdened by their illness? Which is kind of begging for the answer that no, this is meaningful to provide this care. And that may be very true, but I don't think that it takes away from the fact that those are real feelings that many people have as they get sicker and as they approach the end of life. Many people care a lot about not burdening their loved ones, and they may not want to be in a highly dependent condition for a long period of time. There is an article published by Karen Steinhauser et al., and they talked about different things that people feel are important as they approach the end of life. Clinicians' expectations about what might be important to people at the end of life are different from what patients think is important. And a high percentage of patients really felt strongly about not burdening their loved ones with their care. So I think it's important that we keep that in mind and that we try to care for them in ways that can alleviate that concern.
Can you define what feeling like a burden among ALS patients actually looks like and might even feel like?
What our group found to be a predominant theme here, which is a long-held and long-standing belief about not wanting to be living in a highly dependent state. We also think that there's a financial implication of ALS that may be more salient than with other terminal illnesses. People living with ALS often live for a prolonged period of time in a state of marked debility where they may require, for example, 24/7 caregiving help. And because of the cost of that caregiving help, of various assistive equipment, there are significant financial implications in that period of debility that may be on people's minds as they contemplate the next steps in their ALS journey.
Clearly, people with ALS in advanced stages have a disability. Can you talk about how that plays a role in your research and in the connection between aid in dying and ALS?
I think there's really significant differences between ALS and a chronic disabling condition. ALS is a rapidly and inexorably progressive terminal illness. It gets worse consistently with very little hope of disease stabilization, let alone improvement. And people realize that they will die from this illness, likely within a short amount of time. So I think that does make ALS a very different condition than a chronic state of disability as we think about how that relates to aid in dying.
So it is important that we recognize that for some people living with ALS, the quality of life is enough to continue to live and to not ever maybe entertain the idea of aid in dying. And at the same time, in our clinical experience, and we know from the literature that these inquiries or requests for aid in dying are so relatively prevalent among this population that we do feel the need to explore motivation for that as well.
People with ALS care a lot about having control. If there's anything we can do to improve their control, give them a better sense of agency, that's what we should do, as those are significant issues that weigh on people with ALS, most highlighted through our work. Additionally, people with ALS do fear dying of a respiratory death, and we need to make sure that we do everything we can to make their disease course and their dying process comfortable and assure them that there is an option to die comfortably with this illness. Further, people worry about burdening their loved ones. So there's work to be done so that people living with ALS and their families are not completely exhausted by this illness or bankrupt by it.
This has been a wonderful discussion. Thank you again to Dr. Caroly Bischoff and to Dr. Caroly Rennels for joining us in this discussion about ALS and aid in dying.
Thank you so much for the opportunity.
Thank you.